Good afternoon and welcome to today's webinar, What to Expect in Your Internal Medicine Rotation. My name is Karen Tucker Labella. I'm Director of Education for the New York Chapter ACP. Before we begin, I'd like to review a couple guidelines. All participants will be on mute since we have such a large audience. If you have a question, please type it in the dialog box at the right and I will read the questions to the panelists during the webinar. We also received questions in advance from the online registration form. These questions will be addressed following the presentation by Imran Chaudhry. Imran is our NYACP Medical Student Advocacy Intern and a fourth-year medical student. I will be sending the handouts to all participants, and we will have a recorded version online on the medical student page on the chapter's website at www.nyacp.org. Our speakers today are clerkship directors Dr. Joseph Wayne from Albany Medical College and Dr. Michael Licurcio from NYU School of Medicine at Langone Medical Center. I'd like to now welcome Dr. Wayne and Dr. Licurcio.
Thank you, Karen.
Thank you, Karen.
Oh, sorry, Mike. All right. So thank you all for coming. And so what we plan to cover here are just general topics and guidelines for how to kind of survive your clerkship and how to do well. But actually, a lot of this doesn't apply just to medicine clerkship. It will apply to all the clerkships you go through in your third year. So we just want to put that out there. Since we're medicine, we're going to start briefly with talking about what is internal medicine. And this is the outline that we're going to follow here. It looks like a lot, but I think we will cover it in a reasonable amount of time for you. So we will go ahead and start with what is internal medicine. Probably the best definition comes from the ACP, American College of Physicians. You can see internal medicine physicians are specialists who apply scientific knowledge and clinical expertise to diagnosis, treatment, and compassionate care of adults across the spectrum from health to complex illness. I think one of the important words in this definition is that we are specialists. We're diagnosticians, care providers, and patient care managers for all our patients, and especially in the changing world of primary care medicine with patient-centered medical homes, our care management skills and knowledge of how to handle multiple complex diseases becomes increasingly more important. This is kind of the foundation of what medicine is. And you can see this is from the National Academy of Sciences. And this was came out after the reports on the rates of diagnostic errors and how bad things might be in medicine. I think there's one report that shows it's safer to fly than to be in a hospital. But so this came out as a response to try and change that. And so when we look at this, this kind of is the guideline for what the clinical process is, which is different than the process in the first 2 years in taking exams. So we start with patients. They come in with a symptom. We gather the information. We interpret that information, integrate that into other information, come up with a diagnosis, which helps us do diagnostic testing and then referral. And then we keep going round and round here to make sure we don't miss anything, because patients don't necessarily always tell you all of the correct information the first time through. So it's just think of this as a big wheel, and every once in a while we come out to communicate the diagnosis. We initiate the treatment, then follow up on the treatment, which is more information. And so we kind of continue in this loop for good clinical reasoning. I always like to emphasize that if you look at the big wheel, 2/3 is about information gathering and understanding the information. And don't forget up here in the inner circle, history and physical exam are still extremely important in getting to that diagnosis. Next, we're going to talk about the expectations for you at this point. And one of the things a lot of places use now is this framework for evaluating and assessing. I'll use the term learner progression through their clinical training. And it's called RIME, and it stands for Reporter, Interpreter, Manager, and Educator. Basically starting on your third year rotations, and for the whole of third year, you're basically are going to be reporters. Your key function is to be a reporter. What does that mean? That means you're going to gather all the patient information. You have to be able to put that information together in a format that makes sense. You have to be able to communicate that information, both verbally and in writing. And you also have to do a little bit of interpretation of the data. You have to be able to understand what abnormal labs mean, what abnormal physical findings mean. So that's where the interpretation comes in. When you look at this, we're going to come back to this slide at the end when we compare third year and fourth year and talk more about how you progress along this algorithm for clinical learning. And we'll talk about this later on when we talk about clinical reasoning down here. So again, in medicine, you will learn a lot, and oftentimes people say they learn the most on their medicine clerkship because there isn't anything we pretty much don't cover or deal with in internal medicine. We may refer out for specialty consultations, both within and outside of the field of internal medicine, but we still work to take the history, make a diagnosis, and decide that that referral may or may not be necessary. It's an opportunity to become familiar with common acute diseases and chronic illnesses, and I always try to emphasize that always remember common things do occur commonly. A lot of students will try to impress with mentioning zebras and things, rare diagnoses or unusual conditions that we don't normally see. And really your test is more on these exact things right here. The subject exam, not so much rare and exotic diseases. Like when I see someone in heart failure, I don't think of beriberi, but that's something a lot of students bring up in their differential. And I'm like, I've been doing this for 30 years, guys. I've never seen beriberi. So stick to common and acute things and thinking and reading as you're progressing through the year. You'll see inpatients and outpatients. Again, this is going to depend somewhat on your individual institution. Here at Albany, we're 12 weeks long, so we do 8 weeks inpatient, 4 weeks outpatient. Some are just 8 weeks of inpatient, some are 6 weeks of inpatient, some are 6 weeks inpatient, 2 weeks outpatient, some are 4 and 4. So depending on your institution, you may or may not get this mix, or the outpatient may be a totally separate rotation, perhaps as family medicine. Anything to add, Dr. Locurcio, on that?
Well, I was just thinking that at NYU we have 8 weeks of inpatient medicine followed by 4 weeks of ambulatory care in medicine. So in effect, even though we separate into 2 clerkships, that's identical to what you do up in Albany. Mm-hmm. Just going back to you know the idea, when you're a student and you're starting out clinical medicine, a lot of students are overwhelmed with about the amount of information they have to master when looking at internal medicine, and it's because we take such good care of a wide variety of diseases. This is the reason why you will learn more in this clerkship than most of the others, and it's also why students can become overwhelmed with all the information. But the key is to communicate your thoughts. I agree that you should always think of common diseases first, and that is the majority of what you're tested on. But when you see that a patient does not behave the way you predict, if you go back to that original wheel that Dr. Wayne had reviewed, one of the key factors is, well, the patient isn't behaving as I'd expect them to. You really have to abandon your paradigm and refocus. Well, why doesn't it fit? What is different about this particular case? Why, or maybe I'm wrong, and you have to reinvestigate. And a lot of students up to this point, you know, what's the correct answer? It's usually C when you're a graduate student. But when you're a clinician, sometimes you're doing learning, adjusting all at once, and it can be very daunting. And my advice to the students is don't get overwhelmed. I mean, it's a lot to take in. You're not expected to do the clinical care. you're there to learn from very experienced clinicians.
Okay, right, and yes, that's a great point. So, all right. So moving on for the expectations, what is expected of you when you show up on the wards? There's some basics again. It's going to vary from school to school. Every clerkship director has an orientation and probably an orientation packet that gets distributed to everyone. Certainly review that carefully and in detail to make sure you understand everything that's going to be happening during the clerkship and what the expectations are at your institution for what you're going to be doing on the wards. Be certain to attend all your activities and be on time. Our time here is pretty proscripted. We don't have a lot of time to waste, whether we're on inpatient service or seeing patients in the office. So show up on time everywhere for lectures, learning sessions, rounds, and things of that nature. Always just dress professionally. One of the things I like to say in orientation, because of the changing fashions and changing times, is just remember what may be fashionable may not necessarily be professional when you're wearing it. So think about that, and most places will also provide you with what they expect as a dress code. And if they say this is the dress code for the employee, then you need to pay attention to that, because one of the things I think of too is you're basically now in on-the-job training. I try not to think of you as being in school anymore. And when you go to meet patients, everyone has their particular way to do it. We say, introduce yourself as I'm student Dr. So-and-so. My chairman likes to say, if you tell these elderly sick patients in the hospital that you're a medical student, they're going to look at you and you're going to look young enough to them, they'll think you're just a high school student. So better to say something like I'm a student doctor or I'm a doctor in training, along with your full name to introduce yourself as a general guideline. You can be sure you want to deal with every member on the team with respect. Sometimes you may be on a team with someone you don't like or don't get along with, but from a professionalism point of view, you do have to be collegial and respectful as best you can in a situation like that. Don't do anything to upset any of the other team members or make yourself look bad. Keep in contact with your residents. The worst thing you can do is disappear suddenly from the wards and not be around without the resident knowing. So if you're going to go to the library to get an article, just say, I'm going to the article to get a library, or be sure to tell them I have a meeting with my advising dean, or I have a doctor's appointment. Just tell them where you're going. Don't just disappear, because that doesn't look good, because they're going to call the clerkship director and say, this student's disappearing a lot. And that's never a good thing for the clerkship director to hear. So when you do get pages, depending on how your school chooses to contact you, whether it's pager, text message, or email, be sure to check those things on a regular basis and to respond in a reasonable amount of time. If you write notes, if you have to write paper notes, write them clearly. Most everyone now is pretty much using an electronic record. But in that note, you always want to make sure that your name is clearly spelled out. And if it's a handwritten note, you want to print it, and you want to make sure it's clear your name is MS3 on there. And preserve patient confidentiality at all times. Once you put that coat on, that white coat, everyone just assumes you're a doctor when you're walking around the hospital. They don't know that you're a student or any different from us. So when you're talking and discussing patients, be sure not to divulge any HIPAA-related information anywhere. Don't be talking about your patients in the elevator or walking down the halls or even in the cafeteria. You may never know who you're sitting next to. So that's always, and that's a big issue that we see all the time. Anything to add on that, Dr. LoCurcio?
I agree with everything you said. I just always remind students that you're not dressing for me, you're not dressing for your resident. You're now a clinician and you're dressing for your patients. There is a point in during this clerkship year when you recognize that it's not about you, that your patients are the most important thing. And there are studies that are pretty clear. They respond well to people who act in a professional manner. And you'd be surprised at just how much and how powerful your position in society is when you put your hand on someone's shoulder and say, I think you're going to be all right, or I think we're going to get through this together. And it has a lot more power when you are a professional.
Most certainly agree. All right. Our next topic along the way is professionalism. This is always key. It's explicit and an important goal of the clerkship. I always tell students it actually is 100% of your grade for us here and probably for many places. Unprofessional behavior is criteria to fail the clerkship in and of itself. I don't care if you get a 98 on the subject exam, if you're unprofessional to anyone in any way that gets back to me and I hear about it, you will fail the clerkship. I think that's pretty standard. Knowing your patients well and understanding who they are. You guys have more time than anybody else. Once you're on the ward, you'll see how busy the residents and the hospitalists are with their patient volumes and trying to get all the other things done for the patients in terms of their care. But you have time to be able to sit down in the afternoons, go back, check on your patients, talk to them, see how they're feeling, find out what are their concerns about what's happening with them. And you can always relay that information back to the team, either formally on rounds or informally say to the resident, I was just talking to the patient and they told me this. You'll be surprised what patients will divulge to you once they take you into their confidence. And don't be afraid to advocate for your patient. Speak up for your patient. Sometimes they're afraid to speak up when this huge team of people is around them. But you can advocate for your patient as well. At times, reflect on your actions. Think of, was that a good thing? If it wasn't, think about how you might do it better, or ask someone, I did this. I don't think that was such a good idea. Maybe I should do this, a different way I could do it. Don't be afraid to ask. It's our job to help guide you and on these topics and on these issues so that you truly do remain professional. Have empathy for your patient. Always feel for your patients and acknowledge that. Oftentimes during observed H&Ps, I worry that the students aren't empathic, but they tend sometimes to save it up at the end when they tell the patient this must really be hard for you. And I hope things will work out in the end, but some sort of empathic statement. And don't be afraid to say, I don't know. Okay, the worst thing you can do is make up an answer, guess an answer, or even make up lab results. Just say, I don't know, and go find out and get the real results. So someone says, what the radiologist say about the x-ray, and only you and the resident looked at the x-ray, but did not either see the written report or check what the radiologist say. I don't know what the radiologist said, but I'll make sure to find that out. And always learn from your mistakes. Medicine probably isn't a good profession for that, but we still must learn from our mistakes and figure out how to do better. This is your time to be able to do that. You may be doing stuff that, although may directly impact patient care, you're still not responsible for the patient care at this point. So there's ways that you can figure out how to correct things that you see go wrong. And be observant, okay? If you see errors, report it. Many places now have secure and non-discoverable patient error reporting as part of quality improvement projects, so that systems, if there's a systems problem, such as getting a medication to a patient, there's many steps involved. Maybe there's problems doing that in a timely fashion. You can see something and speak up about it, and someone may take action on it. That would be a good thing to do. So don't be afraid to bring up mistakes to other people as well. This is a slide I use in my orientation. I usually tell them this is the baseline for professionalism. This is where we all start. This is what we bring to the table. This is kind of a neat little summary of how to behave and be functional on the wards and with your team. So being on time, having good work ethic, coming in early to see your patient, staying a little bit late if you need to, making sure all your work is done is important. Putting in the effort, trying to help out other team members, not slouching down or leaning against the wall on rounds. Be energetic. Have good attitude, be passionate about your patients and their problems, be coachable. So when someone says, you know, I don't think you did a good job on that, don't become defensive. Say, all right, what could I do to do it better? And be open to being coachable and feedback. Do extra work, and which would go along with your work ethic and work effort, and always be prepared for rounds. Make sure you have as much information as you think you possibly need to know to present your patients and convey information when you're on rounds. Anything to add to that, Dr. Locurcio?
No, I agree. I just wanted to state, just to clarify something you said, and that is, you know, it's 100% of your grade. But just to clarify, professionals make mistakes. I make mistakes all the time. It's that commitment to learning from them that will distinguish you as a professional. I couldn't agree more about don't make up anything. Being truthful is probably one of the most important things a clinical clerk can bring to the team. And I always like to say, make sure your team will miss you when you're gone. You know, they're going to remember that student who was contributing significantly, and when they are going to be saddened by the end of your clerkship, you know that you've done a great job.
I like that. Yes, make sure the team will miss you. That's really good. I like that. And the last thing I would throw in is don't be afraid to admit when you make a mistake. We know the literature is ripe with doctors who try to cover up their mistakes. They're the ones who get sued. The doctors who admit their mistakes pretty much don't get sued. The patients appreciate the honesty that you made a mistake. They understand that we're all human and that humans are not perfect. So, all right. So learning effectively, how can you learn in the third year? All right. Well, third year is much different than learning in the first 2 years. First 2 years is a lot of general knowledge and information that you're gathering. So at this point, by the time you finish years, your memory muscle's pretty strong at this point. You know, you know a lot of stuff. I like to tell my students in orientation, you've pretty much learned everything you need to know, but knowing it's not enough. All right, you know facts, you know odds and ends and minutia, and you're good at memory and recalling these information. But from this point forward, once you start third year, the learning changes. Okay, and now it's a marathon. So you need to train for the marathon. And it's all about learning. And as I mentioned earlier, your patients don't hand you a fully written H&P on them when you walk in. They're going to blurt out a seemingly unrelated fact that you have to take, synthesize those facts that the patients provide, and apply the knowledge you have from the first 2 years to create information that will lead you to a diagnosis. That's a big difference from just reading and remembering and taking tests in the first year. A lot of places introduce clinical problem solving or problem-based learning, which is a way to help. But I think a more global issue in medical education is everybody studies to the test, which is kind of the big difference between what should be happening in the later years of medical school in the first 2 years. So how does it work? It's a combination of stuff. It's experiential learning during the day. Always listen on rounds. Pay attention to everything that's being said about every patient. Yes, it's an overwhelming amount of information, But one of the things that you'll probably see is that a lot of the same conditions come in. You hear a lot of the same things. So repetition of all this information starts to build up synaptic connections in the brain that make it easier to recall that information later on. And then when you go home, you're going to be doing a lot of self-directed learning. There is no reading list. I tell the students you can't go home and read the chapter on respiratory diseases in Harrison's textbook of internal medicine because you just can't do it. It's impossible. I couldn't do it. So what you want to do is you want to write down questions that you think about or from the patients on rounds. I didn't quite get that. I need to look that up later. I mean, you could also ask your attending and resident to maybe clarify it, but if you still don't get it, then write it down to look up later. Try to know the most about your patients. Know more than the intern. Try to know more than the resident if you can. But know as much about every one of your patients that you are writing notes on and following as best you can. Be that team player. And again, learn from all those patients. Ask for feedback. Actively ask for feedback. And then always be willing to look up new articles and literature and be able to read that information critically and bring that back to your team, especially in conditions that newer treatments are needed or it's an unusual situation that requires some unusual form of treatment. That's where going to the evidence works. And then always, as always, learn from your teachers and listen to what they tell you about managing the patients, how to go back and do a better history, and everything of that nature. So I mentioned self-directed learning. I'm just real quick from adult learning theory. So what is it? The process by which individuals take the initiative with or without the help of others to, you first want to diagnose your learning needs. What are you going to learn? That's why you're going to write it down and then look it up later on. Formulate learning goals for yourself or the clerkship. What are you looking to be able to improve upon over the course of the clerkship? What do you really want to learn to get out of this? So if you're going into surgery, maybe you want to focus on patients who come in with abdominal pain. There's lots of abdominal pain that ends up in surgery, so you can learn a lot about how different things present in internal medicine with abdominal pain while you're on internal medicine that you can apply to other clerkships and rotations. Identify your resources for learning. Your clerkship directors will do this. Your residents will guide you to some sources to use, but use the ones which you find will work the best. So just pay attention to when they're telling you where to look stuff up. And then select and implement your learning strategies. Figure out how you learn best. Everyone, we all know learn differently, and there's all these neuroscience behind memory and learning, and you got to figure out your methodology that works. And if it's not working, ask someone. Ask one of the residents, one of the interns, a fourth-year student you're attending. I'm really having trouble getting a grasp on this information, and what can I do? And they should ask you, what are you doing? And then from that point, they should be able to help you. Anything else to add on learning effectively in the clerkship, Dr. LoCurcio?
No, I agree that it's very varied for each learner. The one thing I always say to students, I just wanted to pick up on your statement about knowing your patients. Up to this point in your career, it's likely that you looked for your professor to be the teacher. And one of the key things that you're going to realize soon is that you're trading the classroom for the wards, but it's the patient who's going to teach you everything you need to know about the impact of disease. If you know them well, if you understand the impact of that disease on them personally, you're going to have a better understanding of what it really means to have diabetes or whatever disease it might be. So learn from them, and they will teach you. And I always also like to stress the fact that your team members and your attendings, well, they kind of can guide you in your self-directed learning, but it's the patient. Learn from your patients.
Okay. Good. Thank you. All right, so next we're going to briefly touch on clinical reasoning, which is really the key of putting all that information together. So that's what it really means when you can hear the story and get to a diagnosis. There's at least 3 basic types of reasoning. There's hypothetical deductive reasoning, or backward thinking, which we'll talk about. It sounds negative, but it really isn't. Algorithmic thinking, which is forward thinking, and then pattern recognition. So the hypothetical deductive reasoning is more the backward reasoning. So this is where you basically generate a long list of differential diagnoses. And then you work backwards by knowing the disease that you've mentioned is differential, and work it back to match up with what the patient is telling you. So you're kind of working from a long list to kind of take things off your list or rearrange them in a more orderly progression based on how well they compare to the information that the patient has presented to you. The problem of hypothetical deductive reasoning, it's a little inefficient. It doesn't necessarily prioritize in a good fashion, but it is a good starting point to develop your reasoning process on getting to the diagnosis. Some people apply anatomical approaches, some apply systems-based approaches. I'm big on trying to get the students to compare and contrast the disease history with the patient history and how do they compare to try and get to the diagnosis. The algorithmic approach is more forward thinking. You progressively add in more information. There's lots of clinical algorithms. A lot of these you'll find in the pocketbooks that you have, and certainly in the textbooks. They have all kinds of algorithms for how to approach UTI, how to approach chest pain, things of that nature. This is just an example. I'm not going to go through this, but what an algorithm looks like for a patient who's found to be hyponatremic. So we would break it up into 3 different processes and then go forward from there, choosing what test to order and how to interpret those tests. Last on clinical reasoning is pattern recognition. This is where, as the information comes out, a pattern of symptoms becomes apparent and then leads to the diagnosis. This is what a lot of your attendings and probably residents are capable of doing because they've been doing it for a while. It's the one thing the students always, and I always wondered when I was a student, was how do you get there so fast? And it's because we've been doing this for a long time. We've been able to assimilate a lot of information to a certain diagnosis. In the memory process, we've chunked in a lot of other information together. So in the synaptic pathways, they kind of all lead down one pathway that gives us to the diagnosis, which is why when we hear certain things, the pathways light up and the diagnosis comes out. It really isn't a lot of thought process. It's more reflexive type of thinking, but it does require a lot of background knowledge about disease pathology, natural history of diseases, the varied presentations of the diseases that you see that you can only truly gain with experience and having seen them. So that's something that you'll be striving to as you work through all your clinical training and all through your clinical life. So what I like to say to my students is this is the kind of pattern recognition most of you have at this point. It's kind of but your patients don't come to you in such a nice, neatly packaged presentation. They come in more like this, more like a word cloud, where they're just scattering out random facts about themselves. I always give the example, you have someone with abdominal pain, and you ask them, trying to get the quality of the pain, you say, what's that pain like? And the patient goes, oh, it was like when I had my gallbladder out. And boy, back then, and they start talking about their gallbladder. And then you have to try and figure out how to redirect them to the history. So they don't come in very neatly, packaged presentations. And it's tough to sort through all that information to put it together in that pattern to recognize the disease. But as I said, with experience, the pattern recognition comes with being able to filter out the things that don't matter or aren't important to the things that do. Anything to add on that, Dr. Locurcio?
Just a suggestion to, to take every case that you can see. And what I mean by that is some students I'll hear, well, I've already had a case of abdominal pain. So can I have something else? And it's true, you should look for a wide variety of cases, but sometimes you'll get to the point of pattern recognition once you've gone through the same symptom multiple times and you see different flavors of it. So try to balance totally different diagnoses or different symptoms and don't be afraid to see the same thing 2 or 3 times during your clerkship. I think there's value in both.
Yep, that's true. Okay, so we're going to finish up here with success on the inpatient setting and then outpatient. So again, a lot of this we've probably already talked about for success in the inpatient setting. So as Dr. LoCurcio just said, be involved in care of as many patients and as many cases as possible. Care for everyone you're assigned to and pay attention to everyone that's on the team and on rounds. Most importantly, always have that information about your patient ready for rounds, including their vital signs, lab results, and everything. Use a notebook or index cards to scribble down little notes on your patients so you're ready to be prepared on rounds. You don't want to be walking around carrying your chart or large 8.5 by 11 pieces of paper. Be active in rounds. Put yourself out there to present your case. If the attending says, all right, let's hear about Mrs. Jones. And then there's the 10-second pregnant pause between you and the intern for who's going to talk. If you're following that patient, just start talking as soon as the attending says the patient's name. Don't look at the intern like, should I talk? Just start doing it. So that's how you would be assertive. An important thing, too, is always be organized. Start to try and develop a pattern for how to get through your patients in the morning, to pre-round on your patients, how to organize the information, how to organize yourself, too, throughout the clerkship. Make sure to put things on your calendars, on your devices for noon conference at this time, at this day, or I need to be at a lecture here for this, for the clerkship, or whatever it is the assignments you have to be, so that those will give you reminders. They'll always pop up for you. When do I have to hand in an assignment? Put all those on there so that you stay organized, don't fall behind. And don't get calls from the clerkship director saying your assignment's late. Why is that? You want to try and write as many histories and physicals as you can. Practice does kind of make perfect in this instance, but I think to the point of Dr. LoCurcio, seeing all the different ways that one disease can present will make you better and in clinical diagnosis and a stronger clinician for that. So the more you see, the more variety of it you see, the better it will be for you. Again, don't be afraid to communicate with your patients. You have the time, as I said earlier. Take time, go and sit down, talk to them, spend some time with them. Sometimes they just want to talk about their grandparents. They may not want to talk about, or their grandchildren. They may not want to talk about being in the hospital. They just maybe want some little company and somebody else to talk to. And always, as always, again, be a team player for your team. Help out anyone that needs your help or that looks like they need help. Another issue is the big thing here is presenting the patient. So as we mentioned earlier, for the reporter, you're going to gather the facts from the patient, synthesize it, and turn it into information. And then it's important to be able to communicate that information both verbally and in written form. Again, here there's a lot of variability in how to present. Some attendings like it this way, some attendings like it that way. We always, the bottom line is always try to follow the standard rubric for the history and physical when you're presenting a new patient, and for a lot of places use SOAP notes or whatever format they use for their progress notes, to use that format in the presenting of your patients. Talk clearly, speak up so everyone can hear you, and emphasize important areas. And the worst thing you can do is sit there and just read off your notes. As I mentioned earlier, with the first 2 years, your memory muscle is pretty strong. You can remember four patients' vital signs and physical exams to present on rounds without having to look at notes. You should be easily able to accomplish that feat without difficulty. So again, as I mentioned, adhere to the H&P format. You can play an HPI on and on. Keep it formal. Don't editorialize. Don't put in comments. Don't say I don't think the patient was right, or just don't make any comments. Save all those for the end. Okay. The assessment and plan is where you get to put in your opinion as to what you think it is the diagnosis, what you think is going on with the patient. That's the time where you get to put your thoughts forward. The beginning is really just the facts. It's like the old Dragnet series with Sergeant Joe Friday, just the facts, ma'am, just the facts. The history and physical is pretty boring, but the assessment and plan is where you get to stand up and shine. So practice this and do this as much as possible. Don't be afraid to put your diagnosis out there. If you have something that's different than what everybody else said, you're going to present it, but you're also going to present your evidence along with it. And sometimes, you might just be right because you've had the most time to talk to the patient, and maybe you did get a critical piece of information that the patient forgot or couldn't recall at the time the other provider saw her or him. And then wait to the end to ask any questions of the attending or the resident to see if you missed anything or if there's anything else that they want to hear from you. So anything, Dr. Locurcio?
Oh, that's terrific. I do notice that students tend to struggle when the patient is unable to provide a lot of clear history. And I just want to encourage everyone listening, it's okay to say the patient is not a reliable informant, so I'm going to stick to just what is objectively, what objectively happened. And I think skipping over all the different stories can be helpful. And you're allowed to cut through a lot of the things that may or may not be true by stating that the patient's not reliable.
Very true. All right. So success in the outpatient setting. Okay. So first and foremost, when you go to a doctor's office or a clinic, you want to make sure that they orient you to the site, how it's set up. Where do you put your stuff? Is there a break room? Can I bring my lunch? Where do I put my coat, my books, my computer? They should tell you how they're going to assign the patients to you. And then they'll also tell you how or if you will be documenting your experiences with the patients, whether it's an official note in the chart, whether it's a separate note in the EHR, whether it's just write a note, give it to me, we'll review it at the end of the day. All kinds of different variations happen. Sometimes people put limits on how many patients the student should see in a day. We know that having a student see one patient usually adds about 20 minutes to a day. So we try to be conscious of that and let the preceptors know, maybe then students can see 2-3 patients a day, but there are plenty of preceptors out there who will let you see as many patients as you want. I'm an old guy. I've been doing this a long time. Whenever I have a student in the clinic with me, they pretty much can see my entire schedule. And the funny thing is, I probably get done quicker when the students see my patients. But don't be afraid to ask to see more patients. It's a little different than inpatient. You're going to have all kinds of different things. You're going to have wellness visits. You're going to have chronic disease follow-ups for hypertension, diabetes, lung disease, and you're also going to have acute visits, chest pain, runny nose, cough, fever, chills, dysuria, all kinds of different things will present themselves to the office. So a lot more opportunity there to see undifferentiated illnesses, perhaps in the outpatient setting, and to read and learn about their presentations. Again, don't be afraid to present. Don't be afraid to present the patient to the attending. Use the chart history to get past medical history and stuff. You don't have to go into the room and ask the patient their medical history. The charts should be available to you the review with the patient, but don't go in there thinking I have to ask past medical history, social history, etc. You're going to focus your questions in each of those areas depending on what the patient is there for. And the last thing, of course, is in the outpatient, always being knowledgeable of the preventative and screening guidelines, because that is a lot of what we do in the outpatient setting. Anything to add, Dr. LoCurcio?
Just that outpatient medicine for students can be very challenging. The patient might be very well known to the attending physician that you're presenting to. They may have a long history, and you know, knowing what your preceptor or what your attending physician knows about the patient might be a key factor in how you present a case, and learning how much detail to add in. It takes a lot of nuance, and I'd say it's even more challenging than presenting on the inpatient service when there's a problem to tackle. So this is the place to ask for feedback. You know, after your first presentation, say, this is my first time working here. What can I do to make this better? That's a great place to ask.
Mm-hmm. Yep, that's it. That is a great place to get the feedback. So, okay, all right. And last, and just finishing up before we get to questions, is going to be looking at the difference between third and fourth year. We all know that everyone progresses over the course of the year. They do get better clinically. Students at the end of the third year are far better clinically than students at the beginning of the year, because they begin to start building on their knowledge from each rotation as they move forward, which is what you're going to be doing now for the rest of your life. But as I said, for third year, what most people believe is the minimal basic requirement is that you are the reporter, so that you're able to gather all that information, put it together, and report it back in an understandable and organized fashion, along with synthesizing the information in labs and having some interpreter skills at this point on what's going on, being able to come up with a diagnosis and perhaps maybe recommending some basic plans. To give you an idea of how this might work, I usually tell the students, when you present a patient who has community-acquired pneumonia, you present the history, you come up with pneumonia. Your idea of a diagnostic and management plan would be to say, I'd get a chest x-ray and treat them with antibiotics. That's a perfectly acceptable response. As an MS4, you might say, I want to get a chest x-ray, see what it looks like, maybe get a CT scan, and I will treat them with ceftriaxone and azithromycin. And then as an intern, he's going to know the dosing, the doses, the dosing intervals, and he should know those things down pat. But those are just the examples of kind of minimal acceptable responses at the level of training for these individuals along this framework of reporter, interpreter, manager, and educator. So anything else to add on that, Dr. LoCurcio?
No, I think that's a very useful paradigm to use as students grow into doctors.
Okay. So with that, we'll open it up to questions. So Karen, does Imran have some pre-written questions for us?
Yes, Dr. Wayne, thank you very much, and thank you, Dr. LoCurcio. We have a few questions that were sent in advance, and I will now let Imran share them with you.
Okay, so the first question is, what are some internal medicine rotation specific challenges that you've seen medical students face?
Go ahead, Mike, you could start.
There are many. So if I can clarify, the question is, what are challenges that students face?
Yes.
You know, for me, especially early on in the clerkship year, I see students really struggling with this transition from graduate student to trying to become a physician. They'll often ask the wrong question about simple things. For instance, can I go to a lecture this evening? and they're just asking permission from me. And I think that a clinician would say, you know, I've taken care of all my patients. Everything is tucked in. There's something I would like to learn, and I plan to come back and after the lecture to make sure my patients are still okay. That's my plan. And I think my point is a clinician understands that their actions have an impact on others, their team, and they take responsibility for it. And I think the students who show some sort of immaturity, it really shows. Another thing that students tend to struggle with in the clerkship year as a whole is just some of them get so caught up with studying for the shelf and competing with each other, they forget how wonderful clinical medicine is. They miss out on all the wonderful things that they're doing and their team is doing. And so my advice there is really, you got to stop and smell the roses. It is a wonderful thing to become a physician and enjoy the process. It's not easy. It's hard work, but you will never forget the stories of what happened to you during your clerkships. I remember my internal medicine clerkship that was about 20 years ago. I remember it like yesterday because it was so impactful. So stop, smell the roses, enjoy the process, and work hard. Roll up your sleeves and get in there.
Yep, I agree with that wholeheartedly.
Okay.
So another question we have is, how important is it to figure out what specialty to pursue as soon as we start rotation?
I would say it's not important at all. I think it's better to focus on general knowledge and let subspecialty thoughts and plans come in later. I mean, if you're thinking of at least in internal medicine, the goal of internal medicine residency is to train general internists, not specialists. I prefer people who go in with an open mind and tell them to keep their mind open because sometimes it changes. And I'll tell them the story. I had someone in my office in June, asked me to write a letter. They were going into surgery, comes back in the middle of September and says, can you write me another letter because I changed my mind and I want to go into psychiatry. Sometimes things will happen along the way that will change your mind from what you think you really want to do. So, and I see that happen much more than people stay on track with their desire to be a subspecialist or a specialist.
Yeah, I agree. I think one of the most important things, though, is when you're on each clerkship, you are a surgeon when you're on the surgery clerkship. You are an internist when you're on the internal medicine clerkship. You immerse yourself in the entire process for each clerkship. Within internal medicine, the one mistake I see students make is, well, even if you want to be a cardiologist, I think that's wonderful. But if that means you only see cases related to the heart, that's your mistake. You must look at all the other fields and learn and be even more focused on those other fields. So I think there's a great danger in trying to figure out what you want to do and then sticking to it because you'll miss out on so much.
Another question we have is, how do you ask a resident or an attending to write a case report?
I would say if you identify or someone says, wow, that's an interesting case, that's a hint to say, ooh, should we write this as a case report? And don't be afraid. Just say, do you think this is worth writing up as a case report? And see what they say. I encourage you to say, if no one else wants to write it up with you, bring it to me. Bring the information to me. I'll help you do it. But yeah, no, don't be afraid to ask that question of anybody.
Absolutely. And if you decide that you you will write up a case with, always invite your team, invite your resident and the attending to make it better, invite them to give input. And then when you're ready to submit it as a clinical vignette, I suggest taking a look at the, on this same website, you'll see that the ACP, we just created a webinar, we just completed a webinar rather, with information on how to do that with the ACP, how to submit it.
We have one final question. It is, what characteristics should an ideal medical student show?
Enthusiasm.
Yep, enthusiasm for everything that I think we talked about and said earlier. I think looking at the slides on the professionalism and I still like the 10 things that require zero talent. Those are the best starting place for anybody who wants to do well on medicine. If you do all that, you're probably going to do fairly well.
Right. And just make sure you balance that enthusiasm with a commitment to make certain that your colleagues, your other students also shine. You've all heard the term gunner, and that's really one where a student is trying to get all the attention. You can be enthusiastic, and you can be enthusiastic about how wonderful your colleagues and how great your fellow students are.
That's great information, Dr. Licurcio and Dr. Wayne. That's all the time we have, and we actually ran out of questions at the same time, so it worked out well. I'd like to thank both of you for today's webinar and those of you who participated for this hour-long session. Like I mentioned before, we are going to have the recorded webinar on our website at nyacp.org on the medical student page, and I'll send the handouts to you who are on this today tomorrow morning. Everybody enjoy your evening and have a good night. Thank you. Good night.
Thanks.
Thank you, Karen.
Good night.